recent information as well. So when we talk about liver failure, we always use the word acute liver failure. Acute liver failure, by definition, as you all know, is liver failure in the absence of any pre-existing liver disease. That means you don't have any chronic liver disease, and suddenly you get acute injury, and that leads into liver failure. And then most of the patients that we tend to see in the hospital are what we call acute decompensation of end-stage liver disease. So these are patients who kind of progress to cirrhosis, have had decompensation before, and then suddenly have worsening of their condition again, usually due to an acute event. We're always trying to find out what that precipitating event is. The terminology acute on chronic liver failure is defined as acute deterioration of either known or unknown chronic liver disease. And this is where you will find that some of the definitions do change or differ. So there's two broad groups which have defined ACLF in slightly different ways in terms of what, where in timing of diagnosis. The European Association and the North American Association, basically the North American group agree with the Europeans. Slightly different, but in most settings they agree. And for that definition, you have to have pre-existing cirrhosis to say that someone is currently in ACLF. Whereas the Asia Pacific guidelines, you don't need cirrhosis actually as the prior diagnosis. You can have chronic liver disease and go into ACLF. So that's a big difference in terms of the definitions. And there are a few others, and I'll kind of take you through some of the details. So that's something to kind of keep in mind when you're defining ACLF, which criteria you're using. And the rationale for the Asia Pacific or the APASL, I'll talk about that as well, why they feel that you don't have to have a pre-existing cirrhosis to call someone in ACLF, okay? So basically the EASL group, they use these two terminologies. One is the acutely decompensated cirrhosis. This is development of the routine complications that we think about in cirrhosis, ascites, encephalopathy, GI bleeding, usually variceal bleeding, or any combination of these in patients with underlying pre-existing cirrhosis. Acute on chronic liver failure, they define this as development of a syndrome, usually associated with very high short-term mortality rates. So death within 28 days or 4 weeks after a hospital admission in someone with an acutely decompensated cirrhosis. And you have to have three major features to kind of define this. One is, this is one of the key things in the EASL group, the European group. It has to be in the context of intense systemic inflammation. So there has to be an acute insult, which leads to a lot of a pro-inflammatory process, usually in the like a septic-like picture. So you have to have this intense systemic inflammation to kind of precipitate someone into ACLF. And this is one of the key areas where the Asia Pacific differs in definition, actually. As I mentioned, usually develops in a close temporal relationship with any pro-inflammatory event. For example, acute infections, acute inflammatory conditions like alcoholic hepatitis, hepatitis B, for example, either acute or reactivation. And I'll kind of go through into details. And the third thing is that associated with either single or multiple organ failure. So even one single extrahepatic organ failure, if they have it, they meet the criteria of ACLF. And I'll talk about later on in a few slides. For the North American group, you have to have at least two organ failures, extrahepatic, to fit the definition. That's the only difference. Otherwise, the North American and the EASL group definitions are very similar. But the point being that the inciting event, the start of the definition of ACLF, is once there's already significant systemic inflammation, whereas the APASL definition is much, much early on, and I'll explain it. Okay, and this is a North American consortium, very similar definition, but as I mentioned, you have to have at least two extrahepatic organ failures, in contrast to just one for the European group. Okay, and how do you define organ failures? This slide, gives the definition. And for anyone interested, I'll share all these slides. I'll give it to Dr. Hiley, and anyone can have these slides if you're interested. So basically, so these are really kind of end organ damage. That means really progressive disease. For kidneys, you have to have dialysis or other forms of renal replacement. For brain, significant hepatic encephalopathy, stage 3 or 4. Circulation, so there are 4 things which you're looking at. One is kidney, brain, third is circulation. You really have to be in a shock-like picture. And then finally, respiration, need for mechanical ventilation. So it's telling us that this multi-organ or organ failure, the extrahepatic organ failure, has to be significant to be defined as part of the ACLF. So keep this in mind, because the more, as you will see later on, the more organ failures, the worse the prognosis. One of the key things, this terminology of ACLF is so important, is because you want to recognize it early and intervene very early. And the reasoning because of the very, very high mortality rates within the next 4 weeks. So you got to do something. And of course, you have limitations when you're in a setting, for example. One of the solutions is liver transplant, and if liver transplantation is not an option, it becomes difficult. But at least recognition, and even if you're in a position to transfer a patient to where a liver transplantation is done, you got to do it quick rather than wait for the next step to happen, because it could be too little, too late, actually. So that's the whole idea of understanding and always thinking about anyone who gets hospitalized with a complication of cirrhosis, to think about ACLF. Okay. Now, the APASL terminology is different, really based on the setting. So again, everyone understands you got to have an acute insult. And I'll kind of go through them in detail. For example, Hep B reactivation, acute alcohol injury, like acute alcoholic hepatitis. This manifested as complications that you see in chronic liver disease, jaundice, coagulopathy, and then followed by more significant disease like ascites and encephalopathy. For APASL definition, so this is the original definition, you don't have to have cirrhosis. So that's one of the key differences between this and the European North American group. And also, it does not have to include extrahepatic organ failure. So that's the second difference, actually. So you can have someone with chronic liver disease have an acute insult and really get worse, develop decompensation. Per the APASL group, that defines ACLF. That's first thing. 2, you don't have to have even one extrahepatic organ failure. You still are defined as ACLF. Or the APASL group, and we'll explain why that is, why they think that distinction. Okay. Again, the extrahepatic insults, other extrahepatic insults like sepsis, GI hemorrhage, are not viewed as precipitants but as complications. Whereas for the European group, that is a precipitant. So again, that's a big difference, actually. Okay, and the rationale for APASL to use this definition is that their argument is that If you have someone even without cirrhosis, and on top of that, if you get an acute insult, if which is very, very, very severe, you can actually decompensate and present clinically exactly as someone who has ACLF as per the other criteria. So that means your liver disease can really get worse even without cirrhosis if the acute insult is very significant. And we have seen that before, right? You have someone with chronic liver disease, no cirrhosis, but the acute insult, whether it's severe alcohol use, Hep B reactivation, drug-induced liver injury, for example, it translates to severe decompensated liver disease. So that's a rationale. Apazil says, you know what, you don't have to have cirrhosis. You can get the same presenting picture even without cirrhosis. Of course, if you have someone with already cirrhosis, the intensity of that insult doesn't have to be that severe. It can easily tip you over into decompensation. So if you're just looking at the patient in front of you with decompensation and not know anything about their underlying chronic liver disease, that fits into criteria as ACLF by Apazil, whether they have cirrhosis or not. So that's a big difference between the two definitions. And I'll kind of go through a bit more in detail. Now, they have actually updated this a few years ago. And for the primary event, again, it's the same thing, either acute hepatitis or whatever the event is, followed by jaundice and coagulopathy. So they still feel that's important. They've slightly changed the new definition. Again, it's an acute hepatic insult manifesting as jaundice and coagulopathy, complicated within 4 weeks, followed by ascites or encephalopathy. Again, undiagnosed chronic liver disease or cirrhosis associated with 28-day mortality. One of the things they've done is they've expanded these acute insults, and I'll show that in a short while. So initially people thought the acute insults are mostly either alcohol or hepatitis, but now we know acute insults can be a wide variety of them. So understanding that a lot of things can actually precipitate liver disease decompensation is also very important. Okay? So this is what they very nicely actually kind of take us through. One is normal liver. If you get an acute insult in a normal liver, that means no pre-existing liver disease, that is defined as acute liver failure. And that I think everyone kind of agrees with that. If you have someone with chronic liver disease, and they get an acute insult, if they get liver failure, all the features of the classic liver failure, that defines as acute on chronic liver failure by Apazil. Now, of course, everyone includes cirrhosis as well. So even when someone with compensated cirrhosis, even a first insult can cause decompensation. That again defines as ACLF by the Apazil. Now, whereas EASL takes it to the last column, actually. So you almost have to wait till the last column to start defining this as ACLF in their criteria. That's a big difference. So you have someone with at least who have had one big event before. Now they get another acute insult going into liver failure. Now you start defining the ACLF by the EASL group and the North American group. So this is a big difference between the two definitions. And I'll talk about the significance of it in a short while. Now, coming back to, so what are the precipitating factors of ACLF? One is hepatitis B reactivation. We all know about that, and I'm not going to go into detail. I do have some slides at the end with some updated slides if you're interested. When does this happen? When should you, what are the clinical features? And when should you think about even prophylactic instituting therapy? Reactivation of hepatitis C, it's a rare phenomenon. So it has been reported as a precipitating event. I've never seen one, but it has been reported, especially in countries like Europe and some parts of Asia. Hepatitis A, E, or D superinfection. So again, these are acute infections superimposed on someone with chronic liver disease or cirrhosis. Any bacterial, parasitic, or fungal infections, again, can be a precipitating event, actually. And then non-infectious causes. So the prior slide shows infectious causes. These are non-infectious causes. Acute alcoholic hepatitis. Now, drug-induced liver injury is part of the definition. As you know, all of us are seeing a lot of drug-induced liver injuries. Again, if the insult is big, that can precipitate ACLF. Autoimmune hepatitis flare sometimes can present as ALF, but in someone with prior underlying chronic liver disease, it can precipitate ACLF. Acute variceal bleeding has been added to the list. Another new thing which has added to the list is acute vascular events, acute hepatic venous outflow tract obstruction, or acute portal vein thrombosis, where it suddenly compromises the blood supply or causes acute congestion, can precipitate ACLF. And then surgeries. We always talk about surgeries potentially decompensating someone. And sometimes actually people present for the first time in liver failure, unknown that they have had liver disease after a major surgery. So all of them are come under the precipitants, okay? Again, I'm not going to go too much into detail. Hepatitis B reactivation, I just wanted to kind of show a couple of slides quickly. It's just basically a sudden increase in Hep B replication, and downstream complications include very inflammatory state with very high enzymes, and then that can precipitate an event. And as you know, when we're using a lot of biologics these days, you have to be very cognizant about, is someone at risk for reactivation? So anyone with hepatitis B surface antigen, or even with certain drugs, prior exposure but currently resolution, are still at very high risk. A great example is Rituxan. For Rituxan, you don't have to be positive currently with hepatitis B surface antigen. Even if they have had prior exposure and got rid of Hep B, they are at risk for reactivation. So depending on which biologic, which immunosuppressant, we categorize patients into low risk, intermediate risk, high risk. So the highest risk drugs like Rituxan are seen in patients with even prior exposure and now resolution. Now, why is this important? Because if you were to start a biologic or an immune suppressant in that setting, you got to prophylax them to prevent reactivation and prevent potentially ACLF. So that's really the rationale to think about these things. Again, I won't go into details. One of the key things to remember is that in Hep B reactivation, as you know, someone who is E negative can become E positive. And in about 20-25% of cases, IgM to core can be detected. So IgM to core does not mean acute hepatitis always. This is a very nice diagram. It's a cartoon that I prepared. I use this mainly for teaching to show that Hep B is such a dynamic disease. You can go from active to inactive, resolution, and you go back to active, especially in the era of biologics. So, and this can precipitate ACLF. Okay. Now, how the way the EASL consortium, they've created a score, what's called the EASL-CLIF consortium organ failure score, and this is used currently now to prognosticate when someone comes into the hospital or when someone is already in the hospital, what is happening to these scores, and that determines their outcomes. So, again, in your own institutions, you can look at this prospectively, or if you have this data retrospectively at the outcomes as well, and see, hey, does this actually fare well in our own patient population? So you have the organ systems, the liver, kidney, the brain, coagulation, circulation, respiration, and you give 1, 2, or 3 points based on how severe they are. So just kind of as a reference, actually. Okay, now you can see here the 28-day mortality rates. As you can see, as the organ failure score increases, and or as you get more extrahepatic organ failures, 1, 2 organ failures, 3 organ failures, 4 to 6, your 28-day mortality actually increases pretty significantly. It's like the trajectory is like a significant slope. And this is important to keep in mind. And as I'll show in a few slides, it is not only important to look at this at the start when someone gets admitted, but also as they go along into the hospitalization to kind of give you a prognostic. And this is why it's very, very important when you see someone in kind of the score going up. What that means is that they are probably in much dire need of potentially needing a liver transplant for recovery. So if you're in a setting where that's not an option, but there is an option elsewhere, to move that patient sooner than later. So that's really the key thing in this setting. Okay, now what a few studies have looked at is that, what exactly is the prevalence when someone already is admitted? What is the prevalence of ACLF among hospitalized patients who come in with look like a decompensation, actually? And interestingly, in the European studies, average is about 20%. That means 1 in 5 people who are getting admitted to the hospital with a complication of cirrhosis have already defined ACLF criteria. And this is important to recognize because those patients' outcomes are going to be much, much more severe. Okay. And then as you go along during the hospitalization, close to another 10% met the criteria. So during a hospitalization, almost 30% actually met criteria of ACLF. So that's significant number. For patients who did not meet criteria when they first joined or admitted, they developed ACLF very quickly after admission, usually within a few days, maximum within 2 weeks. And this is important because in the ACLF, we talk about what's called a golden window period. That means you have a very finite window period where you can intervene and potentially reverse it, which you can't do as you kind of progress, actually. So that's important. And one of the highest prevalence rates of ACLF is among patients with alcoholic cirrhosis. And one of the things, depending on the part of the world, either it's alcohol or hepatitis B, but during the COVID era, it's completely shifted the paradigm in predominantly alcohol. As you know, alcoholism has significantly increased during COVID for different reasons. And that has actually exponentially increased hospitalizations for alcohol-related complications and ACLF due to alcohol, actually. Okay. In this particular study, 30-day and 90-day transplant-free survivals were 30% and 50% respectively. That means about 70% and only 50% were actually living at the end of these 30 days and 90 days. So that's very, very high poor outcome rates. In contrast, for those patients who did not meet criteria for ACLF, it was actually very, very low, 2% and 10%. So that is very, very significant. It's a huge difference. Again, emphasizing the importance of us being aware of ACLF definition. Okay. And what this shows, again, the same cartoon showing that in someone who comes in either initially or who develops ACLF during the hospitalization, the mortality rates exponentially increase. And this also looked at based on the number of organ failures. So as you can imagine, the more organ failures, obviously the survival rates start dropping. And that's kind of expected. Again, this is really without a transplant. Of course, if there's a transplant option, the outcome is going to be transplant and not death. And this is why it's very important that if you have someone who starts developing what looks like just one organ failure, ACLF, even with organ failure, it's very important to kind of start thinking about transplant if that becomes an option, either in your institute or elsewhere. At least that means transferring the patient, not knowing what the outcome might be. And as you get 2 or 3 organ failures, now you're really slipping very quickly into the very, very high mortality rates. Okay. Now, the North American study, they looked at in their own group, and here the prevalence rates were slightly lower. And the reason we think is because, as I mentioned at the start, the North American study actually, to meet the criteria of ACLF, you have to have 2 organ failures. So if you just have 1, of course, you're not going to define it as ACLF. That means your initial rates are going to be lower. So it's really a matter of the definition in general, actually. Okay. Now, what is the pathophysiology? Again, most people feel that there has to be some sort of an inflammatory component, though people don't understand this, but they think this is the most significant role. So anytime there's significant inflammation, you have a lot of oxidative stress and the downstream complications that ultimately lead to decompensation. Excuse me. And things like infections, acute alcoholic hepatitis can precipitate this. In GI bleeding, it's not pro-inflammatory, but it's here the injury is more ischemic. So if you have an ischemic injury, that can again precipitate a pro-inflammatory pathway downstream. And this article from New England Journal a couple of years ago kind of takes you down, the pathways that have been slated as potentially potentiating ACLF. Now, coming back to APASL, and this is important to keep in mind, right? Because you have 2 startling different definitions. And again, like as I mentioned, the APASL is really because they feel that, if you actually identify these patients even before how the European groups and the American groups identify these patients, your potential for reversibility, that means that golden window period is much greater. That means you actually have more room, more time to intervene and have better outcomes. That's one of the rationale. Even with the new consensus a couple of years ago, they felt it was important not to change that definition from the European group. And so this is where the big difference is. So whereas the APASL group really starts the definition much earlier, that means they start before any inflammatory component starts, whereas the EASL group, to define it, you have to start with the inflammation, actually. And so again, the APASL argues that it could be too little, too late. And what the other reason they actually say their definition is probably more important as well, they feel at least it's important, is because they feel that the inflammation is a downstream consequence of another injury, the beginning of ACLF, rather than the initial event. So they argue that what is being used by EASL and North American group as a precipitating event, the inflammation, is already is an outcome rather than the initial event. So that's a big difference between the two definitions, actually. Okay, now I'll end the last few slides with talking about how do we manage. Again, everyone uses MELD, but we use MELD in the US, mostly, of course, for outcome, but we also use it in the transplant setting. One of the key things to remember is that if you just use MELD, it has limitations. In the earlier, if someone has a very low MELD, but if they tend to have more organ failures outside the kidney, for example, your MELD might be low or not that high. So it doesn't give advantage to the patient in terms of getting a transplant. Whereas just the very fact that they have an organ failure puts them at a higher risk of dying. So that's a limitation of the MELD score. It also has a limitation when the MELD is high as well, because there's a limit to how high we can take the MELD for transplant. So if the MELD has a limit, 35 or so, of 40, for example, but if they have more organ failures, that again puts someone at a disadvantage. That there, the MELD also has a limitation as well. So that's something to keep in mind, suggesting that, to prognosticate, to elevate the status of a patient in terms of getting an organ, they argue that, using the Easel-Cliff score, for example, might be a better way in terms of prioritizing a patient for transplant. But the main principle of treatment is diagnosing and treating the precipitating event and being very aggressive with the supporting treatment. So for example, if you have an acute precipitant like an infection, like a pneumonia, skin infections, treat that. Be very aggressive in treating it. Acute variceal hemorrhage, of course, we do treat them with antibiotics, but again, treating the hemorrhage. Acute alcoholic hepatitis, again, there's no standard treatments, so you do the best you can. Hepatitis B, autoimmune hepatitis, being again very aggressive in terms of management. Treat the shock, so start very early, be very aggressive in treating a shock. Again, you all know this, I'm not going to go into details, but the point being that very aggressive support, whether it's fluids, resuscitation, respiratory support, CNS support, coagulation support, renal support, you got to jump in very, very quickly to hopefully reverse it into the other direction. This diagram kind of shows very nicely this report from a couple of years ago, showing what are things that you need to think about and what can you do, the different options based on the organ involvement, actually. And finally, in some countries, people have looked at other things like albumin dialysis. In the US, in some other countries, we have what's called the ELAD, or the extracorporeal liver assisted device. None of these have shown to make a huge difference in ACLF. Now there's some ongoing trials with plasma exchange and few other strategies, actually. And then transplant, of course, the minute you recognize it, you got to think about transplant if that becomes an option. I think recently one of the cases, we were talking in this group was this patient with Hep B who looked like, he was getting into ACLF, but luckily he kind of turned around, and we were actually talking to Dr. Hiley about, hey, this patient may need to go to a transplant center if things don't get improved. So the 1 year if you have 1 or 2 organ failures, the overall post-transplant survival rates are very good and no different from other patients without ACLF. Now, the more organ involvement that you have, once you get into 3 or 4, the outcomes are not as good, 80% versus 90+%, but much, much, much better compared to patients who don't undergo transplantation, which is associated with a high mortality rate. And I'll end the presentation here. The next few slides I'm just going to show quickly is really, I have some slides talking about Hep B reactivation and when to think about prophylaxis. And this is a new, more recent, another way to look at, which kind of breaks it down into, again, high, intermediate, and low risk based on the agents that we use for other settings. And that is important because if someone is a high risk for Hep B reactivation, treat them, prophylaxis. Low risk, you can follow them and see if the DNA is going up. In the intermediate risk, you have options, whether to treat or just follow. So I'll end the presentation there. Happy to take any questions. As I mentioned, I'll share these slides with anyone who's interested.
Thank you so much, Professor Hari. We have some questions, and there is also a case presentation from Dr. Iskandar. I know that Dr. Hari has patients waiting for him at OPD. So can we have just 10 minutes for Dr. Iskandar presentation, and then we go for Q&A?
Yeah.
Okay. So with this, we will go to Dr. Iskandar presentation. Dr. Iskandar, can I share it from my side? Dr. Iskandar is our...
Yes, please. Can you hear me?
Dr. Iskandar is...
Yes.
Okay, we can hear you. He is our senior consultant gastroenterologist who is helping us, and when you have difficulty, we discuss among ourselves. Also, he is a senior gastroenterologist with an experience on luminal and hepatology. Today, he plans to share us a few slides on case that he has faced. You can proceed, Dr. Iskandar. Thank you for discussing your cases. Yeah.
Okay. Thank you. It's good to hear from you, Dr. Hari, Professor Hari. Thank you for the presentation. Actually, I joined in the middle of the session. I've missed some slides, so maybe I'll need a revision or a sharing of the slides.
Absolutely.
If possible. Okay. So I'm presenting two cases, and I'm presenting them kind of unpolished as they happened, and they're quite recent cases. Okay. So the first one is a 26-year-old male. He's from Addis. So a couple of weeks ago, he presents like an acute febrile illness and was started as management with antibiotics. So noting some worsening and development of icterus in a week's time, despite management. And then they kept taking the medication, but he kind of progressed to alteration in mentation in a couple of days. And that was when he happened to come to the clinic I'm working at as an emergency. So he was admitted, there was a treating physician seeing him, and he noted that he has significantly deranged liver enzymes. In fact, SGPT was beyond the machine's measurement on an initial evaluation, whereas SGOT was above 6,000. Alkaline phosphatase was just around less than twice the upper normal raised, less than 600. Bilirubin was about 60. Random blood sugar was very low, 40. Albumin was marginally low. INR was above 3, less than 4. And ultrasound showed acute hepatitis picture and no ascites. So the rest of the workups, Hep B and C screening were negative. Renal function test was normal. Electrolytes was normal. LDH was normal. Chest X-ray was normal. Blood film was negative, but he had marked leukocytosis of above 20,000. So he was kept in the hospital for a total of 1 week. He was kept in the first few days, NPO with 10% dextrose in normal saline fluid, 3 bags per 24 hours. He was kept on PPI, IV daily, antiemetic metoclopramide, TID. He was also given lactulose via NG tube. And since he was restless, he was given haloperidol intermittently. And he was put on double antibiotics. And after a day of worsening, he was started on high-dose steroids. The worsening was both clinical and laboratory. So since the initiation of steroids or otherwise on the third day, the clinical picture kind of dramatically improved. The blood profile started to come down and the CBC almost normalized. And the rest of the examinations were normal. And parallel, etiologic diagnosis was being pursued, and hepatitis A virus testing was done, which has to be done abroad, and we were waiting for the results. And he was discharged in the middle of waiting the results, whereby the laboratory results have come down markedly, but not normalized. And at discharge, he was off antibiotics, but maintained on the steroids, maintained on the PPI and the antiemetic. And he was kind of on low protein diet maintained. So on follow-up a week after discharge, he came feeling quite look again, but with an increasing abdominal girth, and which was proved with an ultrasound that there is a new development of ascites. The rest of the follow-up workups were more or less normal, but the INR has come down to less than 1.8, and random blood sugar was significantly high. And at this point, his anti-hepatitis A antibody, IgM, came and was positive. So he's maintained so far, now is coming the second week. He'll be probably coming in a couple of days on the same management. So with this case, I have a question on the diagnosis. What is the diagnosis? Is it something like a fulminant hepatitis? Can we consider acute liver failure on this patient? Or should we consider some sort of a background chronic liver disease whereby he acutely decompensated, remaining unknown? The second question I would like to pose is, what is the prognosis? Now we have ascites as a new development. The albumin is marginally low. The bilirubin has markedly come down. The INR has decreased but did not normalize.
Is it from my?
Hello? The platelets have maintained normal. Can you hear me? Hello?
Yes. Yes, we can hear you.
Yes.
Professor.
Okay. The other question I would like to pose is, what complications should be anticipated in this patient, given the clinical scenario? And what complications are already there from the clinical picture that we have presented? Can we assume that he's gone into chronic challenge with the development of ascites and the other laboratory profiles? And the other thing is, what was the relevance of steroids? Was it a rash decision to put him on steroids? Did we, as was seen seemingly on the clinical presentation, was it really a dramatic response to the steroids? Was it a natural course of the illness? Or did we prevent something disastrous by putting him on steroids? And the other question is, do we need to screen him, like as part of a preventive advice? Do we need to screen him for hepatitis B past infections and prevent possibly with immunization here? And what dietary advice do we need to give to this patient for any possible short-term and, if possible, long-term prognosis changing advice? So this is the first case in summary. Should I continue with the second case or okay?
I think it's better if we discuss about this first case first, and then we can proceed to the second question, to the second case. What do you think, Professor Hari? I think that's better.
Yeah, that sounds good. A couple of thoughts come into mind. So the way you want to think about a case like this, an excellent points raised by Professor. So I've seen this setting in a couple of settings. One is one thing for all of us to remember is that an acute liver injury, whatever it is, hepatitis or a veno-occlusive disease or alcohol, any acute liver injury, if it is significant, can precipitate as decompensation with ascites and all that. So this could all be still a manifestation of an acute illness, and it might take some time to kind of revert back, actually. And we see this especially in autoimmune hepatitis. Autoimmune hepatitis is classic for that. But obviously with autoimmune hepatitis, you got to treat to get it better. So the question here is that, I'll jump to the question of steroids. People used to use steroids much, much more in the past than more recently. So the rationale there is that, it doesn't matter what the precipitating event is. Even with hepatitis B, we used to use steroids. The rationale being, if you have a very pro-inflammatory setting, can steroids actually help? Of course, in the context of Hep B, steroids can have bad outcomes later on, but short term, they do help. And they've been used in drug-induced liver injury, again, not showing a great much effort. But the important question will be, do they have underlying chronic liver disease? If he actually had cirrhosis, I would have expected him to get worse and not better on its own, even with steroids. But still, he may have some underlying chronic liver disease. We don't know that. Time will tell. If it is all related to acute, things will just continue to get better. But if there's a chronic component to it, now you might be dealing with something more chronic, actually. So that's how I would look at it. I know there was a question raised about steroids in Hep A. Again, you didn't have the diagnosis of Hep A. It came much later on, in fairness. So steroids are, again, not used for the diagnosis as much as the consequent injury, actually.
Thanks so much. Probably this is related to the case also Dr. Biniam has raised. How do you determine the threshold for futility? Who is to seek transplant as your center?
Yeah, so in this gentleman, when he first presented, obviously you start thinking about it, right? We don't know what the outcome is going to be. We don't know if he's going to go into acute liver failure. I'm assuming he was not encephalopathic, so by definition, he doesn't meet criteria for ALF, but he could go into ALF very, very quickly. So what we do is that whenever we see patients who come in, we at least start thinking about it. But once if he starts getting the mentation starts deteriorating, then you got to move fast into working them up for transplant. As long as they're not encephalopathic, they're still not in the ALF stage yet. So you have some room to think about, hey, what else can I do? What else should I be testing for? But once the mentation starts deteriorating, then you'll get into trouble. But so that's one of the things.
Okay, for short of time, we will go to the second case presentation by Dr. Skandar.
Excuse me, but I have one question.
Yeah, by the way, we will also return back to the case.
Okay, then I will present the case, but just keep it in mind. Well, my question is, if one complication could be autoimmune hepatitis in hepatitis A hepatitis, when should we start anticipating that complication, and how should we treat him? How should we treat it that way, if that's the case? And could that be a scenario here is also my question. Okay, so the second patient is a 14-year-old male. He's from Addis. Now he has been like 8 months post living donor liver transplant, and he's been on follow-up. And they came to me as a second opinion, as looking for second opinion, because they noted some rises in liver enzymes recently, and this is like 2.5 months ago. And noted that the tacrolimus level was somehow low for unknown reasons. And I also noted that his donor is CMV positive, and he had a brief course of ganciclovir, I assume. Where the procedure was done in India. So out of just assuming everything could be possible, and this is far too expensive an undertaking to just waste, So I started him with ganciclovir, IV first, then I continued PO after 3 weeks. And I kind of held the mycophenolate for a while and increased on the dose of tacrolimus, which I returned back to the original, or in fact, it was even given under, and I doubled the dose of mycophenolate after 3 weeks. And I was following him for possible T-cell mediated rejection that can be further compromised with a CMV, moderate CMV infection. So, and then I also added a dose of steroids. So now is about 2 months on kind of follow-up. What happened is a new development of exudative ascites, loculated. But prior to this development, he had what looked like an acute abdomen-like event, which kind of resolved. That was kind of localized periumbilical, but resolved without coming to the clinic and treatment. It was only a reporting that I could get from a call consultation. And I just started him on empiric antibiotic for 2 weeks now. I'm waiting for the gene expert from the ascitic tab, but otherwise it's definitely exudative with high protein, high LDH, and more than 3,000 cell count, predominantly neutrophils though. So the other findings with this patient that he looks otherwise okay, not complaining that much, but he had an increasing abdominal girth, and they have noted an incisional hernia and a new umbilical hernia development after the 6 months of follow-up, or the last 2 months. That's what the family noted and what was documented with investigations outside. So I have a question. What is our diagnosis here? Are we entertaining rejection and failure? And what's the prognosis? If this is rejection or whatever it is, by definition, where do we stand?
Yeah, I think Dr. Iskandar is lost. Professor Haring, I hope you have heard his presentation.
Yeah. Again, there's been a lot of chats about biopsy, and I think it is going to be the key
to reject. And how should we?
Dr. Iskandar, you are back. Okay.
Okay.
Yeah, you are lost for a while.
I was lost for a while. Okay.
Yes,
it's a very brief case, so I can go back again with this case.
No,
just with the questions only. You were fine till the
questions. On the questions. Okay, all right. So what's our diagnosis with this patient? Is it okay to consider rejection?
Definitely, and I think one of the rejection and also infections as well, right? Because he's pretty immunocompromised. The question is really, what is happening? Even if it's rejection, is he kind of progressing? Sometimes rejection, it can really go on to very quickly into ductopenic rejection. We have seen development of cirrhosis very quickly as well. The question is, what is driving? Clearly he seems to have component of portal hypertension again, but what is driving it? So you really want to understand. I don't know. Again, with ascites, it's difficult to do liver biopsies, but to me, liver biopsy would be important to really understand what is going on. With the understanding that sometimes when you're on steroids, it's the right thing to do with steroids when you're not sure initially. It can mask some of the effects, but it will at least show you what is happening with the bile ducts. When we think about rejection, we always think about acute rejection, but some of these patients very quickly develop ductopenic, or we call chronic rejection, even as early as 3 months. So you really want to understand what's happening in the liver. Are we just talking about some sort of a rejection, cell-mediated or ductopenic, or is there more to the story? Because otherwise it would be difficult to kind of guide you, moving forward. Of course, if it gets better, everything is fine. Maybe this is just like an acute precipitating event. You might be okay, but you don't know that. So you're really thinking ahead long term. So at some point, getting a biopsy might be very useful. It will set you as a good baseline as well.
Okay.
And to his first question, autoimmune hepatitis with hepatitis A, you have raised that point, Dr. Skunda?
Yes. So with the previous patient, well, I do understand the relevance of biopsy with this patient, obviously. I think we have to do that in seeing the patient on follow-up. With the other patient, what's the possibility of autoimmune hepatitis as a complication, and when should it be anticipated? Can it be de novo autoimmune hepatitis?
It could be. Again, overall, it's still rare, but the point that you're raising is that, viral hepatitis have been shown to kind of precipitate autoimmune, especially with Hep A. The other thing to always also think about, especially if he's kind of relapsing, there is an entity called relapsing hepatitis A, which continues for about a year after the initial event. And that drives the clinical scenario, actually. So if you ask the question differently, hey, could this just be persistent Hep A? That's also could be another thing. If it is either way in that context, if you knew that, especially if it's an autoimmune component. For example, if the first patient, it could be if the autoimmune markers were negative, it could still be autoimmune, and the Hep A could have been just a bystander or maybe a precipitant. So this particular, if there's an autoimmune component, he'll probably need steroids more longer, actually. Otherwise, we always think about stopping them soon, right? So depending on how he's doing, especially if the liver enzymes are still abnormal, they don't normalize, that would be a patient who you want to think about biopsy as well. Kind of resetting a baseline to understand which way he's heading or he will head, actually.
Okay. Thank you.
Yeah.
All right.
Thanks so much. We have some questions in the chat box before you leave, Professor Harun.
Yeah.
So I know you are in the clinic and still I'm in deficit.
That's fine. I can go through them quickly. So first question is, are the apostle guidelines different because of the higher prevalence of chronic Hep B without cirrhosis? I don't think that was a consideration for them as much as this philosophy that, or at least the feeling that, hey, you don't have to have cirrhosis to develop ACLF. They did understand, where they were, Hep B was more common, but they felt that it's not that as much as even without any chronic liver disease, with chronic liver disease without cirrhosis, you can have this. And they recognized later on, after the initial consensus, that, hey, you can see that with a drug-induced liver injury, for example, alcohol, for example, and so you should think about this definition even without cirrhosis. So that was really their big rationale, actually. And then the next question, when to consider ACLF in patients already having cirrhotic liver when there may not be significant derangements of aminotransferases of bilirubin. So keep in mind, this point is important because you can have compensated cirrhosis with completely normal enzymes, normal platelets, for example, normal bilirubin, and all it takes is an event which puts them into ACLF or gradual deterioration. So one of the things I always talk about is that normality of enzymes and normality of platelets doesn't mean that they don't have cirrhosis. So so that one thing to keep in mind. So irrespective of the aminotransferases or the bilirubin, if you meet the criteria, whether you use the APASL or the European criteria, if they're having decompensation, it's automatically, you have to think about ACLF actually. I think we talked about steroids in the first case that we talked about. What do you recommend with giving propylthiouracil for ALF from DILI? I know it's been proposed. There's not a whole lot of data. I think that the Dillon's group are looking at different things in terms of having, the idea is that one is immediate recovery, and two is, preventing chronic disease. Whenever you think about, steroids or, this question about propylthiouracil, you always have to think about, one is benefit, does it do anything or not? Two, also about harm. And so people have taken the rationale that, hey, even if there's some theoretical benefit like steroids or PTU, if there's no long-term harm, why not use it and see if anything helps? So definitely worth trying. Again, the second case, I know a lot of people talked about TB. Clearly, it's high risk. Anything. And then the one question of the original disease, how are the vessels? That's important. I was going to ask the question as well. Did we get a Doppler flow? Because the question is that, could this be an acute hepatic venous thrombosis or portal vein thrombosis, which is precipitated? Because in that setting, you can get very high enzymes, actually, with either, mostly with hepatic outflow, but it has been reported with acute portal vein thrombosis as well. So I'm sure you have done ultrasound with Dopplers, but that's something to think about if that was not done.
Yeah. Thanks so much, Professor Hari, for excellent presentation. Despite you have constraints in time, I think with this we will wind up the session. Before you can please fill the feedback link shared, and if you want to have if you want to share your presentation on EcoSession, you can send us to the email group. Thank you so much. Thank you all.
Thank you so much for thank you. And I would love to have follow-up of both the cases. It would be awesome.
Yes, sure. Dr. Skender, I'll follow up and we will share it to you. Yeah.
I will update you as we go forward.
Thanks so much. Yeah. So wonderful seeing you all.
Good to see you. Good to see you.
Good to see you. Yeah.
Thanks so much.
Thanks
Bye.
so much. All right. Yeah. Bye.